I'm very excited to introduce one of our own chief residents today, Laura McDowell. She came to us from the University of Minnesota, where she earned a BA in physiology, and then followed by her MD there as well, before coming over here to Wisconsin, where she's been one of our rural track residents. She's done some research in rural health and maternal transport. And after graduating here in a few months, we'll be returning to Minnesota to practice in a rural setting, as has been her goal since coming here. So thank you for joining us this morning, and we look forward to hearing more about rural medical training.
Thank you, Dr. Bizzuto, for that introduction. And certainly I'm very excited to be able to talk to you all this morning about rural medical training, the stats, the need, and the future. So I do not have any financial disclosures, but as Dr. Bizzuto alluded to, and some of you probably already know, I have benefited from many different rural training experiences in my education thus far. So certainly do have a bias towards them. In terms of our goals for our time here today, by the end of this talk, my hope is that we will be able to analyze the pros and cons of rural practice, evaluate why a shortage of OBGYN providers exists in rural America, and then discover ways to promote solutions to the rural physician shortage through training track learning. As a guide for our time here today, my plan is to interweave my story throughout our discussion, talking about the three different objectives, with framing that around background information of rural areas, next discussing rural obstetrics, followed by medical exposure to rural life and practice, and then lastly, talking about next steps, how I hope that we will be different from our time here this morning and how it might charge us to move forward in a different way. So first off, starting with my experience and first real exposure to rural living was when in the middle of my second grade year, my family moved to Northwest Minnesota to a town called Alvarado, which has at the time had a population of 356 people. This was a small, close-knit community that truly welcomed our family in with open arms. I was able to call many of these people my grandparents, aunts and uncles, and cousins, as certainly our extended family was at least 5 hours away from us when we lived up in Northwest Minnesota. It was here that I was truly able to see my parents engage in the community in a different way than I had seen them engage in the community when we lived in a distant suburb of the Twin Cities. Here, they engaged in community service activities such as Lions and were both a part of the emergency response crew for the area. And that certainly brought them a lot of pride and respect from the community, and I think also a lot of fulfillment as well. And moving into my high school years, we moved to Northwest Iowa to a town called Storm Lake that has a mixed population of 10,000 people. At the time, this was moving to the big city for me and certainly offered me more opportunities in terms of education compared to what I had experienced in the town. Pictured here is the hospital, Buena Vista Regional Hospital. And learning more about the hospital, it's actually a critical access hospital for Northwest Iowa. It certainly brought a lot of pride to the community, as many people put a lot into the hospital as being a big resource for the area. And it was here that I was first trying to discover what I wanted to do for my future life and career, and thought that medicine was what I wanted to pursue. And so was able to discern a little bit more about what I wanted to go into, whether that be a physician or nursing or forensic pathology. I was a big fan of CSI for any of those also fans out there. But through this experience, I was able to work with a few different family doctors in the community, shadowing them and sometimes even receiving care from them, which I found to be very impactful for my discernment process. Arguably, one of the most impactful experiences of my life in terms of medicine and just life experiences was when I was given the opportunity to travel. Able to spend a month in the southwest region of Tanzania, with highlighted experiences included time in a girls' secondary school outside of Chimala, Tanzania, as well as visiting a rural hospital in the southwest region, and being able to interact with different children that were orphans from HIV. Either personally they were affected by the virus or had their family members that had passed on from the virus and were receiving care in this orphanage. After this experience in Tanzania, I knew that I wanted to pursue medicine, and I actually initially thought that global medicine was where my future was headed. It wasn't until a few years later that I continued to reflect on my experiences and had a desire to care for people in an underserved capacity, but was trying to figure out how that fit into my life. And it somehow dawned on me that I had actually lived in many underserved areas growing up, although I didn't know that at the time, and that these communities were here, local in America, and needed help as well. So that was when I kind of switched my thought process and decided that rural medicine was what I was hoping to pursue in the future. So what is rural? There are so many definitions out there, and if you were to go into Merriam and Webster's dictionary to find a definition of rural, this is what you would find that rural is of or relating to the country, people or life, or agriculture. In terms of a research aspect of rural, there are many varied definitions, but primarily they focus around population size. Based on the Census Bureau data, urbanized areas are classified as having a population of at least 50,000 people or greater, with urbanized clusters being smaller areas of population consisting of 2,500 to just under 50,000 people. And the Census Bureau actually defines rural as essentially a negative of urban. So defining rural as the population, housing, and territory that is not classified as urban. From a core-based statistical area standpoint, which is pictured here in this figure, showing different Wisconsin counties highlighted in different colors, they break down rural and define rural based on kind of a lack of definition as well, but define metropolitan statistical areas as areas with at least an urban cluster, which is essentially a city that has a population of 50,000 people or greater, and its associated social and economic ties within the community. And micropolitan is consisting of a urbanized cluster consisting of at least a population of 10,000 to just under 50,000. Here, pictured in this figure, the rural counties are shown in a white color. A third way to classify rural is put forth in this National Center for Health from 2013, classifying the urban rural classification scheme of county. And here there are 6 different categories to define rural and urban, with urban consisting of metropolitan counties having at least a population of 50,000 people or greater, and they also take into account the metro adjacent status of these counties and amenities within there. In terms of non-metropolitan or rural, they define these counties as being either micropolitan or non-core, with micropolitan counties having a population cluster or city that has at least 10,000 to just under 50,000 population, with non-core consisting of a city cluster with less than 10,000 population. Another interesting thing to note is that not all rural areas are created equal. And so this can be seen here in this heat map, showing that more densely populated rural areas tend to be clustered around cities or urbanized areas, which intuitively makes sense, but it is helpful to know that not all rural areas are the same, especially. So moving into assessing our kind of own background knowledge of rural information, we'll be next going to a poll, which hopefully maybe is working at this point. But if not, certainly you can put your answer in the chat, and it's just more of an understanding basis for us.
We'll have to go with the chat for this one. I'm still working on it.
Perfect, no worries. Okay, so the first question is, what number of the US population in 2010 resided in rural locations? Answer choice A is 30 million, B 40 million, C 50 million, D 60 million, E 70 million. Wow, getting a lot of great responses. All right. Well, wonderful. Maybe some of you are really good, fast Googlers. So for this question, the answer is actually 60 million. So based off of the census data from 2010, the rural population consisted of at least 60 million folks at that time. And as you can see in this figure here, they further broke down the percentage of rural areas based on each state, with Maine actually being the state having the most rural population. Now on to our second question. So what percentage of the US landmass is considered rural? Answer choice A is less than 50%, B 50 to 60%, C 60 to 70%, D 70 to 80, E 80 to 90, and F greater than 90%. Wonderful. All right. So for this, the US actually has greater than 90%, and actually specifically 97% of the landmass rural, which is, surprising in and of itself. I know that this stat was something that was mind-boggling to me as well. But I think what is also more surprising is actually that 80% of the US population lives within 3% of the United States land. So I'm happy to see that there are other people that are surprised by this statistic as well. So some of you may remember from my research presentation about a month ago, this figure from the National Center for Health Statistics 2013 Urban Rural Classification Scheme, depicting the different United States counties based off of their one of their 6 designations, with again rural consisting of micropolitan and pictured here in green. It still might be surprising that out of this, 97% of the United States landmass is considered rural, but nonetheless, that is the statistic. And if you remember, the rural population consisted of 60 million people. And of that 60 million people, 28 million were reproductive aged women that lived in these rural areas. And that number of women accounts for 35% of the entire US reproductive age population. So good numbers to keep in mind. Not only are there difficulties with geography that affect rural Americans, but this press release put forth by the Centers for Disease Control and Prevention showed that rural Americans are at a higher risk of death from the 5 leading causes of death, which include heart disease, cancer, unintentional injuries, chronic lower respiratory disease, and stroke. They also reported that rural Americans are often older and sicker than their urban counterparts. They have higher rates of smoking, hypertension, and obesity. They typically spend less of their leisure time in active pursuits. And when they are driving, they are less likely to wear seatbelts, which can predispose them to motor vehicle accidents and their subsequent complications. In addition to these risk factors, there is a higher rate of poverty in rural America, and they also have less access to health care. And there are more rural Americans that are less likely to have health insurance as well. From this data from the Kaiser Family Foundation, it discussed that 24% of the non-elderly rural population utilized Medicaid services as their payer for different hospital. Interestingly, Medicaid, it's been reported that you typically pay 87 cents on the dollar of actual cost. This is operating at a deficit in terms of finances, whereas private payer insurance typically reimburses about double of what Medicaid does for hospital services. And considering the outpatient setting, private payers reimburse about 2 to 2.5 times more than Medicaid for these types of services. So next, we will address our first learning objective, where we will be analyzing the pros and cons of rural practice, understanding that there certainly is variability for each person in terms of what is considered a pro and what is considered a con. According to the American Association of Medical Colleges, they put forth an article describing the different reasons of why physicians choose to not pursue rural practice as their career in the future, noting that an increase in call burden is an issue. As providers out there, so you tend to be taking call more often compared to their urban counterparts. The rural physician typically is on the more wise and knowledgeable side, with having the average age of rural doctors being around 51 years of age. And so there are thoughts and concerns about the potentials for retirement and kind of worsening that call burden. Additionally, if the physician has a working spouse, living in a rural area can sometimes be challenging to find meaningful work for that spouse. In terms of children, if there are children involved, the educational opportunities can be a little bit more challenging, especially when considering going into high school years in terms of advanced placement or college classes in high school. Some rural areas are unable to support this kind of advanced learning for those students. Another potential challenge of rural practice includes the issues with rising medical debt and tuition costs put forth by medical schools and even undergraduate education, and a concern that physicians that choose to practice in a rural area may not be reimbursed to the level that they would need in order to pay off that debt. And lastly, there is considered this generalized culture in medicine that there is greater value placed on subspecialization and specialization itself. And so being mindful of that when we have medical students that might be considering a primary care field, and knowing that that is a much needed area for people to fill in as well. So kind of looking more into the facts of specifically looking at the concerns of medical tuition and debt issues, the government actually created this National Health Service Corps loan repayment program in 1970, which was intended to help mitigate the concerns of costs for different healthcare professionals going into underserved and rural areas. The goal of this program is that different healthcare professionals would commit to a predetermined number of years of service in this underserved or rural area, with these areas designated based on a number scale, having higher numbers being consistent with more destitute and resource poor areas. This paper, published by Pathman et al., looked at the kind of outcomes associated with the National Health Service Corps and showed that having a National Health Service Corps physician in an underserved or rural area did actually attract, on average, 2 additional non-Health Service Corps physicians to the underserved area. However, despite this, it did not actually result in that underserved area losing its underserved designation. So certainly there are other things afoot creating this underserved environment. Now moving into some of the advantages of rural practice that some rural physicians have reported include that they enjoy living in a rural town in a social sense. They have this sense of belonging and feel like they are able to be community leaders in their. In terms of benefits from rural practice, they have noted that clinical autonomy and also practicing the full scope of their training can be areas of advantageous benefit to them. So what are the facts around this as well? There have been many studies published about physician satisfaction in rural areas, with this study published by Pathman et al. Reporting that rural physicians find some of the greatest satisfaction in their work in rural areas pertaining to the patient-physician relationship and giving them a sense of fulfillment for providing care in this kind of underserved. They note that having clinical autonomy is something that they enjoy, and also enjoy partaking in small town life. This study, put forth by Cutchin, describes rural retention as a bond between the physician and the place that they are going to. And this has many different external effects on the physician themselves. But that what I thought to be most important and impactful was that the integration process truly starts with initial recruitment. And so the physician or learner is trying to discern whether living in that particular location is something that they could see themselves doing. And so having that exposure to rural practice and rural life is something that can aid in this integration and retention process. So going back to some of my experiences, as we discussed earlier, I certainly grew up in many different rural communities in my formative years. And so moving into college education, I really wanted to try to see what the big city was like and experience that kind of difference in living. So I chose to pursue my college education at the University of Minnesota in the Twin Cities, and certainly received a great education there. I was able to meet several wonderful people, many of them pictured in these photos here, and was able to create smaller community for myself in this bustling metropolis. Despite that, though, I always felt like there was something missing, some sort of connection that was lost compared to my growing up years. And so with that in mind, I knew and kind of came to find out that living in rural areas where I was wanting to focus my life, as I have certainly felt more connected and grounded in these rural areas compared to urban. Much to my delight and excitement, I was accepted into medical school at the University of Minnesota in Duluth, where the first 2 years of lecture-based studies were, certainly focused on learning medicine, but they also integrated learning in regards to rural practice as well as Native American health. They had this unique program called the Rural Medical Scholars Program, where 5 weeks of our first 2 years of lecture-based studies, we actually spent in a single rural town in either Minnesota or Wisconsin, learning from a family practice doctor, and essentially got to follow them around and see patients. It was here that I was able to practically apply what I'd learned in medical school by doing histories, performing physical exams, generating different differential diagnoses, and attempting to formulate plans. But truly what I enjoyed the most about these experiences was that I was able to interact with patients again and feel like I was somehow making a difference in their lives by seeing them and providing them different solutions to their concerns. Moving on to the third year of medical school, we were given the opportunity to either continue our learning in the clinical wards down in the Twin Cities, or to participate in a longitudinal integrated clerkship, which they called Rural Physician Associate Program, or RPAP. I truly wanted to understand more about rural practice, and so chose to pursue this training track as a way to further that educational understanding, and was selected to go to Hibbing, Minnesota for that learning opportunity. It was here I was able to work with many different family practice physicians, general surgeons, pediatric staff, and obstetric and gynecology physicians. And through this, I was able to experience the true gamut of continuity of care. And I was able to see women in clinic and follow them into the labor and delivery floor, which provided me a lot of satisfaction. And I was exhilarated by this kind of experience. And actually through that opportunity, I chose to pursue OBGYN as my future specialty. And I'm very grateful that I did that. So moving into our second learning objective of the day, we will next focus our time on evaluating why a shortage of rural OBGYN providers exists in the United States. So in 2008, ACOG published this committee opinion describing the health disparities seen in rural women. And they reported that at that time, there were 6.4% of OBGYN workforce providers that practiced in rural areas. And if you remember from earlier in the talk, there are 35% of the reproductive age women living in these rural areas. So certainly this is a disconnect and a burden for those women. The Department of Health and Human Services put out this policy brief in May of 2020, describing that there was currently a shortage of 9,000 OBGYN providers within the United States, which was projected to be up to 22,000 by the year 2050. So certainly there is a shortage currently, and it will only be getting worse if we don't do something about it. They also reported that 50% of the counties within the United States are currently without an OBGYN provider, and this results in roughly 10 million women needing to travel longer distances for their basic routine prenatal care, which I'm sure all of us can appreciate is a lot, even with just general normal care in the prenatal period. However, if you have any sort of complication needing to have antenatal testing, etc., that becomes an increasing burden, especially for women that are working outside the home. So now we will be focusing a little bit more about the status of rural obstetrics, specifically in Wisconsin, with some more poll questions. So our first poll question for this set includes how many counties in Wisconsin are actually considered rural, with answer choice A being 16, B 26, C 36, D 46, and E 56. Thank you guys so much for adapting to this chat fill-in. A lot of great answers coming in. Doing great. Wonderful. So in Wisconsin, there are actually 46 counties that are considered rural, and that can be seen here in this figure with the two-tone green counties highlighted here, again being micropolitan or non-core counties. Rural. So our next question is how many counties in Wisconsin do not have an OBGYN provider? Answer choice A, 10, B, 20, C, 30, and D, 40. Awesome job. Being so willing to put your answers in the chat. Truly appreciate that. Wonderful. All right. So there are currently 20 counties within Wisconsin that do not have an OBGYN provider. And of these 20 counties, 19 are actually rural counties, 2 of them being micropolitan and 17 of those being non-core counties. So great job, everyone. Lastly, we'll be transitioning into our last learning objective, where we will hopefully discover ways to promote solutions to the rural physician shortage through training track learning. Through the Centers for Medicaid and Medicare Services, they published this issue brief called Report Improving Access to Maternal Care in Rural Communities, as well as the Rural Report by the American Hospital Association. And these two entities described 4 different reasons for why obstetric units in rural areas are closing. First being low obstetric volume, low reimbursement, lack of skilled providers, and the expense of keeping these providers trained as the 4 main areas and areas to improve in. So since these latter 3 are something that the medical system can address, we will be focusing our time addressing these last reasons for rural obstetric unit closure. So first, discussing low reimbursement. As previously discussed in this talk, Medicaid reimburses about 87 cents on the dollar actual cost provided. This causes hospitals to function at a deficit for providing care. There is ample research out there, especially out of Dr. Casamano's group, about reasons for rural obstetric closure. And I love reading anything that her and her group has to put out, but thought that it would be helpful for us to focus a little bit more on what the general public knows about rural obstetrics and these hospital closures. So this is a Time article that I actually received from my aunt as a magazine clipping this past fall that showed that rural hospitals and states that had not expanded Medicaid following the 2010 Affordable Care Act were at an increased risk of closing their doors, shown here in this bar graph, with 83% of hospitals closures occurring in states that did not have Medicaid expansion. As you can see here, Wisconsin is one of those highlighted states that has not expanded Medicaid to all of its population. So what's more of the current climate, since that data was only up to 2017. So according to the Wisconsin State Journal, this article published in 2019 reported that over the previous 10 years that there had been closure of 11 rural obstetric units in Wisconsin. And within the last few years, in 2017, Grantsburg and Ripon were the two locations that had most recently closed their doors. In this article published in 2019, they had reported that there were 35 rural hospitals that were at risk of closing their doors, with 5 of those hospitals saying that they knew that they were going to be closing, but had not set a date of when that closure would occur. These figures here, put forth by Hung et al., who is a member of the Casamano group, showed the different U.S. counties within America that have had issues with rural OB unit closures. Pictured in the dark blue counties are the counties that actually had complete stoppage of any rural OB unit services, with the medium blue counties consisting of counties that have not had obstetric services during this study time, whereas the light blue counties have ongoing services for obstetric care. Of note, as of February 16th of this year, Governor Evers actually has included Medicaid expansion in his proposed budget for fiscal year 2022 to 2023. However, he also included Medicaid expansion as a part of his budget proposal for the years 2022 to 2021, and this ultimately did not pass due to the legislature. So for those of us that are participating in Doctors' Day next week, this would be a great thing for us to advocate in terms of expanding Medicaid within the state of Wisconsin to hopefully help prevent closure of these rural OB units. For those of you that are unable to participate in Doctors' Day, this would be an opportunity for you to advocate to your senators and House representatives in regards to Medicaid expansion, not only for Wisconsin, but also for other states within the U.S. as well, to help stop this issue of rural OB unit closures. Now moving into the concern of lack of skilled providers, we'll be showing this video from the NBC Nightly News. It highlights a woman's experience after her local OB unit closed its doors back in 2015, where she lives in the Arrowhead of Minnesota, and highlights her experience with that.
Claire Shirley and her husband Dan are third-generation owners of a canoe rental business in the Minnesota wilderness. But when Claire got pregnant, just 1 month after her local hospital closed its maternity ward, she knew she was in trouble.
So suddenly we're looking at a 2.5-hour drive one way to Duluth to the hospital.
She never made it. A half hour into the drive, in active labor, she was rushed to the local emergency room. It had no birthing equipment and no obstetrician. Her daughter was born healthy 25 minutes later. Kristen Wharton teaches childbirthing classes at the community clinic and gets the same troubling question each class.
What if I have to deliver a baby on the side of the road? That is an indication that something's wrong.
It's an issue across the country. In 2004, 45% of rural counties lacked hospital obstetric services. A decade later, it jumped up to 54%.
This is a national crisis.
Dr. Ellen Hartenbach is confronting this doctor shortage that is crippling women's health. At the University of Wisconsin School of Medicine, she designed the nation's first rural OBGYN residency.
I want this program to be a blueprint for increasing training spots in the country.
Hi.
Dr. Laura McDowell, the program's first resident, took me out of the city and into the heart of where she'll be working.
It's just so beautiful.
There's a lot of healthcare is leaving communities like this. Why do you want to come here? Well, just because docs are leaving doesn't mean that the need isn't still there.
To keep them from leaving, Dr. Hartenbach and her team look to recruit doctors who have already embraced rural life and who have some experience in small community hospitals. Laura was the perfect fit.
Women shouldn't have to think twice about getting good quality health care in their small rural town.
A concern for Claire Shirley.
If we do end up having more children, I'm not sure what the plan will be.
And 28 million women in rural America. Dr. John Torres, NBC News, Monroe, Wisconsin.
So hopefully after watching this video, it is clear to see that there is a concern and that this is a personal concern for many, many rural mothers out there, and something that the medical community should be working to address. And thankfully, Wisconsin has been leading the front in that. So lastly, moving on to the one of the final reasons listed as a concern for maintaining these rural OB units in hospitals, I wanted to highlight the issues of expense of maintaining providers training in these areas. There are several papers out there, but wanted to kind of first focus on, what is the actual cost of training, and is training actually effective? So this first paper put forth by Yu et al. Breaks down the costs of and expense of these kind of trainings into startup and variable costs, with variable costs being recurring annual for the hospital. And they accounted that this total expense for maintaining these providers training came into just under 200,000 American dollars. And primarily this expense was related to releasing their attendees and trainers to go to these simulation training sessions. Whereas looking at how effective simulation training actually is, especially in obstetric emergencies, this paper by Van de Ven et al. Showed that team simulation training is certainly cost effective, but it only is cost effective if it is completed in repetition. So doing either, no training or having just one training session isn't enough and is not going to be preventing a composite obstetric outcome. So I hope that that we all appreciate that there are certainly providers that need to be added to the rural workforce, not only in OBGYN, but throughout all of the different specialties in medicine. And, how can we do this, and how can we be affecting change in this area? And I think through certainly my research and experience is that exposure to rural medicine is very crucial and comes both in medical school and residency. Actually working with one of the rural OBGYN providers through this training track experience. He had only grown up and lived in Chicago, and eventually took a job in greater Wisconsin. And he reported that he had wished that from the get-go, he had gone to practice in rural medicine. So, had he had exposure to that in medical school or residency, maybe he would have chosen to pursue rural practice sooner. The issue around this pipeline certainly pertains to finding people and providers that are more apt to practice rural medicine. And through several studies, the background of a person does matter, with people coming from a rural background being more prone to practice in rural areas. This paper put out by Health Affairs in 2017 reported that there was a 28% decline in medical school matriculants from a rural background, with these rural background students accounting for less than 5% of the medical school matriculants in that year. And if you were from an underserved or minority group and a rural background, you accounted for less than 0.5%. So this is certainly something that the medical system needs to address in terms of preventing this and solving a problem for this shortage. So fortunately for me, in 2017, the University of Madison, Wisconsin, put forth this rural residency program and training track in obstetrics. I was so excited to hear about this program initially, and this was always my number one place where and so on match day, I was a bundle of nerves, but was beyond ecstatic when I opened my letter. I actually even let out a Dr. Rice woo, so I'm glad that that fits in here. And I certainly have received an outstanding education here, both in Madison and in greater Wisconsin, in regards to high volume of care and acuity of care, and how to provide that care to women in a sensitive and respectful. I am so grateful for all of the experiences that have been provided. Know that through my exposure and practice in these rural areas has helped to inform my future decision in my career. So I'm very grateful for that opportunity to go out and learn in that kind of way. So what other qualities besides, having a rural background are associated with rural providers? This study by Robert Tate showed that male gender, having lived in a rural location, attended high school in a rural area, or having exposure to rural practice in either postgraduate or medical training were components of rural provider retention. This systematic review, published in 2017, further broke down other factors associated with rural retention and their degree of importance listed here. And as you can see, certainly on the highest level of importance, having a rural background was listed there, but of moderate importance was this rural training track, either in medical school or residency, which is a big component for having exposure to different medical learners to rural practice to see if that might be something they would consider doing in their future. Overall, from this systematic review, they showed that graduates of these rural training track programs were found to remain in rural practice about 44% of the time. So certainly having exposure does result in retention of these providers in rural areas. So I hope that we have been able to understand the importance of rural training in medicine. And I know that there are potentially some people that don't fully appreciate that. I know when I was interviewing for medical schools, certainly outside of the UW system, I had asked about having rural educational experiences on elective months. I actually received a comment from one of my interviewers saying that that was not needed in my training and that I would be benefiting more from experience in an academic center as opposed to a rural area, and that would just be a waste of my time. But I think that the data that we've talked about today is certainly contrary to that. And I think that we need to be doing better especially in the medical school realm. It's been reported that 8% of medical schools have a commitment to rural physicians in their public mission statements. Just under 70% have demonstrated commitment to rural practice in some sort of way, and that 20% of medical schools actually provide the much needed exposure to rural practice. So certainly are areas for improvement. How are we doing in the residency realm? Well, as of 2016, there were 99 family medicine, 16 internal medicine, and 11 general surgery rural training tracks in the United States. And if they had 2017, UW-Madison would be listed as the only OBGYN rural training track. Of note, actually, in 1974, Wisconsin again led the pack in creating a rural training track for general surgery, and that was initiated out of La Crosse, Wisconsin. So go Wisconsin. And certainly through these training tracks, the average kind of retention of these rural physicians and graduates of these training experiences has been quoted to be between 40 to 50%. So hearkening back to these three kind of main areas that the medical system can focus on in preventing rural OB unit closures, I wanted to end our time with that in mind. So first, looking at low reimbursement, how can we be different from our time here today and advocate for some change? And I think that we can do this by talking with our representatives about expanding Medicaid to all states, and also for advocating for higher reimbursement for Medicaid deliveries, as this is certainly for already struggling rural hospitals. For our second point, in terms of lack of skilled providers, increasing the number of exposure to medical practice for both medical students and residents throughout the United States is one of those ways for the medical system to provide experience with rural practice to see if people might actually want to continue their careers and lives in these areas. And then lastly, evaluating the expense of simulation training for providers in rural areas. One of the ways that can be mitigated and shared is creating a connection and a relationship between the academic center and rural hospital sites in regards to simulation training and exercises. So in conclusion, I hope that by the end of this talk that we have been able to analyze the pros and cons of rural practice. Specifically, some challenges that have been noted include call burden, the concern of having a working spouse and having meaningful work in a rural area, concerns regarding educational opportunities for children, issues around medical debt, and then the general culture of valuing specialization and subspecialization in medicine being some ways that medical students actually choose to not pursue more general and rural practice. Some of the advantages of rural practice do include small town social integration and community leadership, having this sense of belonging and the clinical autonomy afforded to rural providers and being able to practice at their full scope of training. Certainly understanding that these different advantages and disadvantages are different, considered differently. Secondly, I hope that we've been able to evaluate why a shortage of rural OBGYN providers exists in the United States in regards to physician retention, which can be related to lack of resources and reimbursement for both hospitals and physicians. Understanding that with a lack of exposure to rural medicine, this can result in just not even knowing that they might like rural practice, and that having this lack of providers certainly affects whether rural obstetric units can remain open. Lastly, I hope that we've also been able to discover ways to promote solutions to the rural physician shortage through training track learning, with having exposure to rural life and practice in medical school and residency being one of the salient points for that. And that lastly, creating a connection between these urban and rural hospitals in regards to simulation training can help also mitigate some of the concerns for rural obstetric unit closure. So this last slide, I actually have not ever been able to make it through without tearing up or crying. So if I do that, I will move on and I will send you all lovely thank you letters. But I will do my best. So Dr. Jacques, she has been just an outstanding mentor these last 4 years, both clinically in the hospital and outside in our various mentor meetings, teaching me often untaught aspects of medicine and the medical career. I am certainly grateful for all that she has done, and she was instrumental in creating this PowerPoint and presentation and helping me polish it, always being willing to go through it with me. On to Doctors Rice, Hartenbach, and Spencer for having the vision for creating this rural program. I will be forever indebted to you all for creating this. Ooh, it's starting early. Okay. So thank you sincerely so much for having the tenacity to start this program and to continue pushing this into the future. Ooh. To the OBGYN department, I am so grateful for all of your teaching throughout the years, both in clinic and outside of the OR and hospital as well. You certainly have all pushed me to be the best young physician that I can be, and I will continue to take those principles with me moving forward. For the rural training site physicians and staff, I am so grateful for having you welcome me into your locations and allowing me to envision myself being able to take care of your patients in those sites as well. You've provided me much needed exposure and understanding of what rural practice truly means, especially from an OBGYN standpoint. To my PGY4 class, you guys, I could not have made it through residency without all of you. I am so thankful for all of the support that you have provided me, and good laughs, and probably a few bottles of wine as well. To residents past and present, thank you so much for supporting me through the difficulties of residency. Certainly when there are challenging outcomes, you guys have truly helped me help pick me up from my bootstraps. So thank you. This last one's going to be really hard. So I will just thank them personally, myself. So to my parents, family, and friends, I love you so much, and would not be here today without your support and encouragement. So thank you. Oh, so these are my resources. I'd be happy to take any questions.
Laura, thank you so much for this. Go ahead, Dr. Ray.
I was just going to say, not only was the talk fantastic, but Laura, your work is so impressive. It just makes me tear up. Thank you. Thank you, thank you, thank you.
Thanks, Dr. I appreciate that.
Yes, this was wonderful. You've got so many great comments here in the chat, and I hope you take a moment to take a look at those. This was a really excellent presentation this morning. Thank you. I think we're unfortunately out of time here, but everyone, thanks for joining us today. And Laura, thanks for a really inspiring presentation.
Thank you.